Thank you very much, Judge Holland, for those kind words. Good afternoon, everyone, and welcome. We are honored to have all of you here with us. I would like to take this opportunity to thank the co-chairs of our Governmental Affairs Committee, Judges Holland and Anita Josie Herring, and also our committee, the committee members, Judge Paula Rosenstein and Judge Michelle Rick. Thank you so much for all your great work to put this program together. You guys are amazing. I've seen them work so hard in the past few months, and also, of course, our superstar Lavinia Cousin back there, who has put these programs together for us for the past 10 years. So thank you, Lavinia. We love you. Thank you. And also special thanks to our congresswomen and men who are going to be here. We have several congresswomen going to walk in and talk with us about these important issues. So we are grateful that they have taken time from their busy schedules to be here. And we also have amazing speakers, panel speakers that are going to speak to us. But also, special thanks to Justice Rush for taking time from her really busy schedule to be here with us today, because she was on her way to the airport. We grabbed her and we say, would you please talk to us about your expertise? And she is truly an expert in this area of opioid crisis. And thank you for being here today. And we, of course, we have our wonderful speakers, and our Nancy Ware is here with us. Thank you. We love you. And also Dr. Jones and Dr. Pinels and Gary Tennis. Thank you all for being here. We are all in for a treat, I'm sure. Thank you for generously giving up your time. So at this time, I'm going to turn it over to Judge Holland, and thank you everyone for being here.
I'm going to refer you to your programs because there will not be time for very long introductions of our speakers. But I do want to bring forth now, because you're right, we're a couple hours between her and catching a plane. So I want to bring to you for greetings and remarks the Honorable Loretta Rush, who took the office as Indiana's 108th Supreme Court Justice in November 2012. After being appointed by Governor Mitch Daniels, and then the Judicial Nominating Commission named her Chief Justice in August 2014. And the bio tells you all, even probably a snippet of the things she does, because we know she's all around the country and extremely busy as co-chair of the Opioid Task Force. Come forward, please, and let's welcome Chief Justice Loretta Rush.
Thank you. While she sets that up, Chief Justice, 2 years ago at the Conference of Chief Justices, they came up to me and said, do you think we should have a National Judicial Opioid Task Force? I said, yes, we should have done it 2 years ago. I know. We should have done it 2 years ago, because I believe that this crisis caught the judiciary flat-footed, very much. So the first thing we did was we had to study, what was our role in Indiana, or not Indiana and then nationally. What are the levers that we can pull to get people to treatment? So what is the role of state courts? Well, let's start with the fact that 99.5% of all the cases, criminal cases in the country are in our state courts. 96% of all civil cases. And do you know what the number one referral source to get people to treatment is, other than self? Does anybody know what it is? Criminal justice system. So here you've got the cases are in the state courts. We're the number one referral source to get people to treatment. We need to get it right, correct? We need to understand the dynamics of addiction. And when you look at it, and I look back, and I've been a judge for 20 years, we should have done this before. Shame on us when crack cocaine had such a grip that we didn't set up a model for addictions for courts to deal with. So what the title of this is the Opioid and Addictions Epidemic, and the deliverables that we'll be doing with the National Judicial Opioid Task Force is bigger than opioids. Opioids is the word right now. There's a lot of money that comes with saying opioids. It's killing a lot of people. It's not saying that. We're seeing a huge resurgence of methamphetamine. fentanyl, in methamphetamine. We're seeing a huge resurgence of cocaine, and now there's something for those of you that are attending the drug court conference. There's Katoom. There's a new thing. So there's always going to be another drug on the horizon. So what we need to set up is the infrastructure that we have in the judicial branch and the state courts on doing it. So I did a survey. I read every report that was done by any entity on opioids, both in the medical, the National Governors Association, National Association of State Legislators, Trump's Commission. And you know what was missing? State courts, the role of state courts. So the Surgeon General is from Indiana, and we have served on commissions together. So I got appointed, I met with him, and really sat down and said, what are the levers we can pull as judges? And there's a lot. The coercive intervention of the court can be a beautiful thing. Those of you that are judges with a criminal docket, I'm sure you've heard from litigants, but for the fact I got arrested, I'd be dead right now. So this epidemic has just been a real eye-opener on what our obligations are and what our role is. And we can't just sit back and think we can just lock people up, have them serve their time, and then get out and that we're okay. Think about this. All the grandparents that in all your states that are raising their grandkids right now, then there won't be another generation of grandparents, right? Because their kids are dying. You have 60,000 grandparents in Indiana raising their grandkids. Who's going to be raising those kids' kids? So, I mean, this really is life or death. And, when you look at getting the information out in the hands of our judges so that they make evidence-based decision-making and understand that this is a disease, it's not a character flaw, in dealing with the stigma of addiction and what their role, it's not a matter of just getting somebody, out of your courtroom. It's really a matter of saving lives. I went back to, I'd been a juvenile court judge for a long time, and I stopped in to see my old probation department. I remember the kids. You always remember the ones, if you're a juvenile judge, that have come before you. Dead, dead, dead. I've gone to 2 funerals of judges in Indiana who lost their sons to heroin. So it's everywhere. So again, it's not just the criminal justice system. We're removing thousands, tens of thousands of children have been impacted. Who hasn't seen the picture of mom and dad lying dead until they get Narcaned with kids strapped in the back seat? Guardianship, conservatorships. We have family members, we have banks contacting us saying, listen, we've got drug-seeking family members. We need to set up, guardianship safeguards to protect their assets. Bankruptcy, financial, business, commercial transactions. We've got a workforce issue, workers' compensation, divorce custody, probation and parole management. So there's not a docket. I keep saying, tell me some case that wouldn't somewhere have some type of element dealing with this addiction. And then when you look at what the opioid crisis has cost the country upwards of $1 trillion right now. So it's huge. So this is what you remember, the National Association of Women Judges. Remember this, the single largest referral source of substance abuse treatment is the criminal justice system. We've got to get it right. So we set up the task force, and we had convenings all over the country. We have 24 different states involved with the task force, and we heard from programs that are working and programs that are not working. What is evidence-based treatment? We sat down with SAMHSA. We sat down with, sent the medical information to Johns Hopkins. We wanted to make sure that the toolkits that we published on the website were evidence-based, because what do we know as judges? We don't know medicine, right? I always tell judges when they say, well, I don't like medication-assisted treatment, and that is that's the gold standard. That's the best treatment that we can give to somebody with a opioid use disorder. Would you ever tell somebody who had cancer, I just don't believe in chemotherapy. I know it'll help you. I know it might save you, but I don't believe in it. So we're working with that, working with prosecutors and sheriffs. But the guiding principles that we had really were a comprehensive approach. One thing we can do as judges is we can get people to show up. When your judge asks you to come, you come, right? In Indiana, we had a statewide opioid summit where I asked the judges from all 92 counties to come and bring a team. Bring your sheriff, bring your prosecutor, bring your community mental health provider. You can pick who you want. Bring your county council person, but bring the people that touch. Every county showed up. We had over 1,000. The whole morning was learning the science of addiction. We had doctors talk about where do these hit in the brain. Then I had a judge, a very popular tri-court judge, cross-examine the doctors. Well, you got us into this mess. Aren't we just trading one drug for another? But And then I had Doug Marlowe, for those of you who've ever seen him present. And then we had breakouts on jail-based treatment, treatment for pregnant women, and we had that, and it went all day. And we started it with actually the judge that had lost his child, and he offered to do this. We played the 911 call when he called when his son was dying. And we ended with somebody that runs our Addictions Coalition, who took 8 times of treatment, and now he's doing it. So it's just those personal stories. So judges, use your roles as convener. I complained very loudly that all the SOAR money that's coming in, state opioid response money that's coming in, the state courts were not getting any of it. I complained enough that I got $11 million. So we are doing SIM training in Indiana. And Dr. Pinales, you're probably talking about that. Are you talking about that in your? Okay, well, you will now, right? The sequential intercept model is, where does an addict hit? Where does somebody with a substance use disorder show? From that not crisis call through the courts to through entry, we're losing people without sort of a warm handoff on what services. So again, we asked our judges to bring a team, and every county got $120,000 to implement their sequential intercept model. And where can we move somebody from the system? Pretrial diversion is a big thing. We've got a money-based bail system now that if you're an addict and you don't have any money, you sit in jail, but if you're a dealer and you have money, you bond out. So we've really got to look at our pretrial reform and going through. So what the task force did, and it was aggressive. I mean, we met weekly on this. We have a series of tools that are everybody can use. They're not copyrighted. There's over 30 of them that are on there. We are developing policy recommendations that we will be presenting to all the Chief Justices at our CCJ conference, and then we're getting this information out, and we can't pump it out enough. If you're having somebody with addiction issues in your court, what is evidence-based? And then so there's some of you that are here from bar associations, great, because we have to have our attorneys know this. Civil legal aid attorney, you may have to school your judges, right? So what better way to school your judges is to print the best practices from the Conference of Chief Justices website on things that work and say, well, here's what all the Chief Justices of the nations have approved. It's kind of hard to go around that. So we have webinars that are on our website, Understanding Addiction. If you have a drug court, I'm hoping that you're getting the PDMP, prescription drug monitoring information, so that you can get a good, clear picture. Here's a map of the sequential intercept model, and I don't know if all this will be available, but it really shows all the intercepts that are delivered by the court. What's really interesting, look at intercept 1, crisis, 911, police start getting called. When we brought our judges and their teams from around Indiana, I thought they'd be really interested in like intercept 3 and 4, reentry. No, they wanted to make sure there are resources at intercept 0 and 1. How do we get these individuals from a preventative standpoint to never go into court? So we're finishing up those trainings right now. And this is sort of the meat and potatoes of the task force, the tools, and all those blue lines. You can click on programs that work. What is evidence-based? We hear that. Well, of course, I don't want to use non-evidence-based treatment, but sometimes we don't know where to go to look for it. What is the court's role? Parent-partner programs, opioid-assisted treatment for adolescents. Medication-assisted treatment for adolescents. You don't think about, somebody 15, 16, 17, they come, they're on butamorphine. Should they, this startles us. So where do we go? And there's resources in that. Then trauma, dealing with trauma and addictions. So we've got worksheets for that and different trauma assessments and how to define them. How do you deal with pregnant women? A lot of people say, well, I want to lock up the women that are pregnant because they'll keep using and hurt their baby. Well, I hear that all over the country. So what is treatment for a woman with opioid use disorder? So we've got the education and collaboration. We have civil and criminal justice, and really just, bench cards on understanding the basics of addiction, judicial leadership and setting up a team, treatment, and that is a MAT bench card. And what it says in that MAT bench card, judges, you're not doctors. And if you have a client that the doctor has prescribed medication-assisted treatment, what are your legal ramifications? What are the legal ramifications? We talk about the ADA and your responsibility on those. Involuntary commitment. We've got some involuntary commitment and guardianship programs with parents are asking to get that. What does it look like? We have every state, the statutes on that. Can it be used? Should it be used? How is it? Fentanyl in the courtrooms. What if you have a case and fentanyl comes in as an exhibit? What happens? Do you have Narcan? Naloxone use in the courthouse. How do you deal with this evidence? And this shows you how to set up that. The fundamentals of screening and assessment. So the sort of the top gold standard tools that are being used. And then we have a lot with regard to rural communities. What we hear, Indiana is a state of rural communities. Well, we don't have resources. So we got models like Montana. They use Polycon, which is a free app, to really connect to their litigants, to their customers. They even have like farmers doing yoga off their Polycon app, because that's part of their mindfulness and their recovery. And it's been very promising. And the pregnant women, we have Tennessee Rocks, which they set up recovery cabins, Judge Sloan, and what that model looks like. And he's now had 90 drug-free babies from women's with years and years. So it's 90 babies that you've sort of broken that cycle on going on to it. And the last one is collaboration and education. The court's role, we talked about SIM. We have transfer agreements. And I think we're going to try this in Indiana. They're doing it in some states. Federal courts don't have the specialty courts. And that was when you look at like the President's Commission on Drug, well, let's get more money for federal drug courts, where there aren't hardly any federal drug courts. So there's a model transfer agreement. How do you get somebody from federal court into a state treatment court? We have 110 problem-solving courts in Indiana. We're really ramping up our veterans courts. I mean, what a beautiful court with regard to rehabilitation and reformation. I mean, if you've never been to a veterans court ceremony, don't die before you go to one. They're that good. So can we get a veteran from federal court? Because right now they're charging the cartels and they go on down. So you've got some of the lower level users that are in federal court that don't even have access to the state treatment court. So we have a model transfer agreement. We got a lot of information from on tribal courts, and to take from a state court into a tribal wellness court, best practices for dealing with our Native American population, both in Alaska and down here. And we worked extensively with them with regard to the tools. And then finally, the model curriculum for judicial training event. This is going to happen in Reno on November 11th to 13th. Every state gets to invite a judge to work with. We're going to have doctors and judges side by side and work with a partnership on developing, and we've already got the bones of publication for Comprehensive Medical Legal Addiction Resource Guide. I just sent a follow-up letter to all the chief justices that I hadn't heard back from. So I think we're like 35 states now. We'll get them there. I'll see them. We'll get them. So we have this. So really, the creation and sharing of a model curriculum on issues of addiction treatment and judicial response. The other promising things that we're seeing is with looking at civil legal aid, legal services, and I served on their national board because it's really not something thought of a lot. But you get somebody through your treatment court, or you get somebody through court, and they had a public defender because you have a right to a public defender, but then you're done, but you don't have your license, you can't get housing, right? You can't get an expungement. So we really need to have that last intercept be getting pro bono attorneys to help them. Housing is a huge issue. If you haven't read the book Evicted, read the book Evicted. Housing is a tremendous issue right now for this population that is working on recovering and struggling, and sometimes those threads that are holding them together fall apart. They say 80% of veterans that are struggling have unmet civil legal needs with regard to maybe accessing benefits. So there are some medical legal partnerships where we have actually civil legal aid attorneys embedded in hospitals and treatment facility, because that might be the first kind of institutional contact to somebody with addiction, and to help them with that range of issues. So my big ask for you is to get on this. We'll be doing a national release at the National Press Club on November 21st. We will have, but everything that's on there is now, as soon as we get a deliverable, we put it on, because why hold on to information and if you're in the middle of a crisis? So please, on your table you have that. Judges, please help school your other judges and attorneys pass this information on, because it really is a matter of life and death, making sure our judges do this and do this right and understand we can't duck from this. I mean, it's here, it's in our courtrooms, and we can really be part of the answer. So that's it. I think I talked 13 minutes.
Thank you, Chief Justice Rush, for not only taking time out to come visit, but for this wonderful PowerPoint, which I hope, Lavinia, we can put a link. We'll put it on our website as a link to this, so we have it now, so we disseminate it among all of our members and anyone else that visits the NAWJ website. While Chief Justice Rush was speaking, we're very pleased that the co-chair of the Congressional Caucus for Women's Issues, Congresswoman Brenda Lawrence, has joined us from the state of Michigan. I know Michelle Ricks is going to clap a lot. Yeah, come on up, Congresswoman. Welcome. Thank you.
Thank you so much. You know, it's always good to have one of your judges in the room, Judge Michelle. It's an honor to be here. Hello, my name is Brenda Lawrence. I'm a Congresswoman from the Michigan 14th District. I represent the metropolitan Detroit area, and I'm proud to be the bipartisan co-chair of the Women's Caucus for this 116th Congress. And I'm also a co-chair for the Democratic Women's Caucus. And on behalf of all the women in Congress, I want to say welcome to the National Association of Women Judges and all the women leaders in the room today, and the few good men who are here too as well. So the opioid crisis is a public health epidemic and is hurting families across the country at alarming rates. So you heard the previous speaker talk about federal funds that we have allocated to distribute to states to fight this battle. We also approach this drug crisis in a different way than we have other drug crises. I'm also the executive board of the Black Caucus, and I have lived through a period where crack cocaine addiction was not treated as, I would say, compassionately as this opioid crisis. I still think that we have some work to do in our judicial system to release those who are in prison because of drug addiction. The numbers that are affected by this crisis are just really disheartening. But what I wanted to just reiterate, as you all know, because of this crisis, more children are now emerging in the foster care system. So I'm naming a lot of caucuses, but these places I'm naming is where my heart is. I'm co-chair of the Foster Care Caucus. And I will tell you, I take in a foster care intern every year in my office. I want to tell you a story of one she was a human trafficking survivor. She told me her story. And I know as judges, you've heard many of these. I said, how did you get in there? Because she's a young woman. She's 20, and she has gone through treatment, and it's really on the right track, thank God. She said, I don't know when I started because my parents were drug addicts, and they used to take money from people to touch and do things to me ever since I've been a baby. So when I got old enough, the stress of that, I started using drugs. And then from using the drugs to support my habit, I got into, human trafficking. This amazing young woman at 20, through this program, was taught welding. And she's just on top of the world. But she said, guess what I'm going to do? I said, what? She said, I'm taking scuba diving classes because I'm going to become an underwater welder. She will be able to get a job anywhere in the world. That is a very unique and high-skilled welder. And my prayers go with her. I mean, her story and her journey is just phenomenal. But as we talk about addressing the criminal justice part of drug addiction in America, I can tell you I was so enlightened that we have finally moved to the point that drug addiction is not a crime. And it's something that the judge, I'm saying Judge Michelle, forgive me, but Judge Michelle was telling me about how she started a court, a specialized court just for those who are on opioids and drugs in her courtroom. And I can't tell you how important it is that you sitting in this room understand that and understand the opportunities that are just laid out. Because when we talk about women who are unfortunately in this space, they're mothers who sometimes have children or even pregnant with children. We're talking about young girls. We're talking about women with mental health issues. We're talking about women who are surviving human trafficking. We're talking about young women who have survived foster care. We are talking about human beings who have endured so many things and unfortunately have turned to drugs. And, you know, we're having an interesting discussion here in Washington about immigration. And it's right now a discussion that's kind of in a unique spot because we have to address the humanitarian part of the crisis that we're having. We need a comprehensive immigration plan. We do have a crisis, but that is no permission for any government to treat human beings in the way that we're treating them at those borders. And I'm saying the same things about those who are struggling with drug addiction. So I sit on appropriations and I'm on government oversight. And in appropriations, I've had the opportunity to incorporate the values of this country and to follow the money. I tell people all the time, if someone tells you what they care about, what they're passionate about, follow their money. And that's where you find what a person really value and treasure. And so we have, through appropriations, really invested in women, in treatment, education, the opportunity for first responders to have the necessary medical devices to save life and to put them in other places other than 911. We are going to have to do a better job of education. I'm looking at this whole discussion about vaping and children being exposed to these e-cigarettes. Isn't it kind of counterintuitive where we went through this whole thing of not smoking and we're almost back to square one? Because I saw a big billboard about Juju. What is that the name of it? Jules, whatever. Yeah. And you're saying, really, are we going to really just go backwards here? So I see the opportunity for us to move forward. And women, I have to say this. You are in a profession of being a judge. And in that profession, you're often taken out of that gender stereotype because you put the black robe on and you know Lady Justice said you must be blind. You're confronted with the same issue, whether you're a man or a woman. We count on you in our judicial system, which is the third leg of our democracy. Understand that our democracy is judicial, legislative, and executive. And if any one of those three aren't working, our democracy falls apart. So you have to continuously evolve. You can't just rest on past practices because our country, our world, our challenges change all the time. And the one thing that women are good at is that, and I like to use the example of the lady who sits on top of this building, the Capitol. Her name is Lady Freedom. She was cast by a slave, and she sat on top of this building before any women were even allowed to vote or any women were walking these halls of Congress. And she has in one hand a sword, and in the other hand she has the wreath of peace. And it captures what our democracy is about. Because there's times we have to stand up and fight for what this country is, our values, our democracy, our country, our freedoms. But also the wreath of peace. That so often the men count on us for the compassion. for the forgiveness, for the inclusion. Because we innately do that because we raise kids and we're forced to do it because the little beings grow up and they teach us to be forgiving, compassionate, despite who they are and what they are becoming. Someone said the reason why God created babies is so you can fall in love with them before they become teenagers. But I tell women, don't walk away from that ability to have compassion. And I tell anyone, a politician without compassion is a criminal. Because if you're sitting here with my responsibilities of policies and laws, and you don't care about people, just think of the damage that you can do. And I would say to every woman judge here that your responsibility, and I count on you so much. I count on you to take care of those issues that are happening and confronting us every day. That issue of locking people up because they're poor and they can't pay their bail must change in America. Because it's poor people. And the example they gave about the person who is arrested for buying drugs and the person who's selling it, who has money, who will get out. And the spiral of challenges and the results of that is something I'm fighting for, and we're reintroducing a bill. Because you cannot force people. Sometimes it depends on the court system. I sit in a very large urban area. A person can sit in jail for up to 6 months just to get their day in court because they are poor and don't have money. So I'm preaching to the choir now. But I want to thank you for being here. Keep doing the work. Know that you have a huge fan here. Every time I see a woman in the black robe, I smile. I want more. But most of all, I want the women to reflect who we are as a country and to know that that third leg of the judicial system must work. And you have it in your hands. Thank you all so much.
Thank you, Congresswoman Lawrence, very much for coming and for that inspiring. I hope you have spurred us on. I think you have to do even more. Before we get to the panel, we were expecting a couple of other of our congresswomen. So I don't want to start if Lavinia is out in the hall, if one is on his way. Otherwise, I'm going to introduce our moderator for the panel. First of all, Judge Josie Herring, don't go anywhere. I told you she was stuck in court. She has made it. My co-chair, Anita Josie Herring, is here. So thank you. We were expecting Congresswoman Brooks. And if she's not here, I'm going to introduce our moderator. Okay, I'm going to introduce her, and the panel understands that we are expecting other congresswomen, and when they come in as unobtrusively as possible, we will kind of give you a chance to answer and then come back. I'm going to introduce to you the moderator for this afternoon's panel, because she has the task of introducing all the other panelists and keeping them going back and forth. So she deserves her own intro, even though there is a much larger bio, again, in your program book. Nancy Ware has over 3 decades experience in the management and administration of juvenile and adult criminal justice programs on the local, state, and national level. She was appointed in 2011 by President Barack Obama to serve as the agency director of the Court Services and Offender Supervision Agency for the District of Columbia. And there's an acronym there. Is it CASOSA? CASOSA, okay. In that capacity, she led over 800 federal employees in providing community supervision for approximately 14,000 adults on probation, parole, and supervised release in the District of Columbia. Ms. Ware brought a number of initiatives to CASOSA, including incentive-focused supervision to augment sanctions-based practice, smaller caseloads based on specialized needs, expansion of training in motivational interviewing, cognitive behavioral interventions, and trauma-informed interviewing. intervention and the launch of the young adult initiative that targeted young men. She expanded the use of video conferencing to facilitate the reentry process for DC Code inmates prior to their release from prison, and this will be of importance and interest to the NAWJ women, to facilitate virtual visits of incarcerated mothers with their children in DC. Nancy Ware is a native Washingtonian, and she holds a bachelor's and master's degree from Howard University. So please welcome Ms. Nancy Ware.
Thank you so much. It's a pleasure to be here, and I see so many familiar faces. We've worked together on so many things in DC, and so I'm very excited about this particular forum because it's such a critical issue. I have a wonderful panel, and I'm excited about introducing them all, and I know that they have so much information, so we're going to try very hard to get them to share as much as they can. And also, I think we're going to pass out cards to all of you if you have questions so that we can be sure that we're addressing your questions and have more time for our panelists to talk. I'd like to start with Dr. Andre Jones. Dr. Jones is the professor in the Department of Obstetrics and Gynecology at the School of Medicine, University of North Carolina. And yeah, the panelists should come up and have a seat. Thank you. She's also the executive director of UNC Horizons, a comprehensive drug treatment program for pregnant and parenting women and their drug-exposed children. She's an adjunct professor in the Department of Psychology at UNC Chapel Hill and an adjunct professor in the Psychiatry and Behavioral Sciences in the Department of Obstetrics and Gynecology, School of Medicine at Johns Hopkins. Dr. Jones is an internationally recognized expert in the development and examination of both behavioral and pharmacologic treatments for pregnant women and their children in risky life situations, and she's received continuous funding from the U.S. NIH since 1994, and she's published over 175 publications. I'm going to move on. There's bios on your table for each of the panelists, and they have extensive bios, so I won't read everything, but I'm going to move on to Dr. Deborah Pinnels. She's a clinical adjunct professor at the University of Michigan Law School. She serves as the director of the program in psychiatry there and law and ethics as a clinical professor of psychiatry at the University of Michigan Medical School. She's also the medical director of behavioral health and forensic programs for the Michigan Department of Health and Human Services. And she's board certified in psychiatry and forensic psychiatry, and she's a diplomat of the American Board of Addiction Medicine. During her career, she's been a clinical psychiatrist in community mental health, inpatient settings, forensic and correctional facilities, emergency rooms, and court clinics. She spearheaded the development of police mental health partnerships and training, and she helped facilitate protocol development and clinical services for treatment courts. She spent nearly a decade in her work overseeing reentry services for inmates with serious mental illness leaving jails and prisons. And she has led and participated in several justice and behavioral health federal grants and is co-developer of Mission Criminal Justice, a model of wraparound services that provide support and aim to reduce recidivism for justice-involved individuals with co-occurring mental illness and substance use disorders. She also received the 2016 Massachusetts Manuel Carballo Governor's Award for Excellence in Public Service as part of a team responsible for the design and development of the state-run intensive women's recovery from addiction programs. She's well-published, and she has worked closely with SAMHSA Gaines Center as well. And lastly, but not least, Gary Tennis serves as the National Alliance for Model State Drug Laws president, and in 1992 through 1993, he served as executive director of NAMSDL's, is that how you? NAMSL, predecessor entity, the President's Commission on Model State Drug Laws. Gary specializes in drafting and developing treatment, intervention, and prevention model laws, policies, guidelines, and strategies. And with the exception of his 2 years service with the President's Commission, Gary was a prosecutor in the Philadelphia District Attorney's Office from 1980 until 2006. The last 20 years of which he served as a legislative liaison for Pennsylvania's District Attorneys Association. and in '87 as chairman of the hiring committee for the district attorney's office. He created the Minority Hiring Recruitment Committee. He was appointed as Pennsylvania's first secretary of the Department of Drug and Alcohol Programs from 2012 until 2017, during which time he served as an officer of the NAWJ board, and he still serves on the board for the National Association of Drug Court Professionals. He was awarded the NAWJ Award for Exceptional Leadership in Support of Substance Abuse Prevention and Treatment in 2014, and the National Ramstad Kennedy Award in 2015, and he's the co-founder of NAMSTIL. So I want to welcome our panelists. They also have additional information about their history that they'll share with you throughout the course of the panel. Okay, sure.
So now that you've met all of our panelists, when we come back from this important greeting from Congresswoman Susan Brooks from Indiana, so let's welcome her, and then we'll go to the panel after that. Thank you.
Hello, everyone. Hello. Sorry to interrupt. This is our life here. Have any of my colleagues been in yet? Okay, outstanding. Brenda's wonderful, and love working with her as co-chair. I'm the recent past co-chair, Republican co-chair. It's Republican and Democrat co-chairing the Women's Caucus. Just came from hearings, one having to do with fentanyl, very relevant to what you all are dealing with and what today's meeting is about, and the other one having to do with wireless, with 5G, the 5G issues and wireless issues and how it's impacting our competitiveness in the world. Two completely different hearings, and now here I am with incredible female judges. For those of you who don't know, I've been an attorney since 1985, and I only sat pro tem a couple of times. I was a criminal defense attorney. I was asked to sit pro tem a couple of times for a friend and it's an incredibly difficult job you all have. I remember sitting thinking, I don't want to make this bail decision. I mean, seriously, and I realized then, early on, quite frankly, that I was more of an advocate and that the decisions you all make are the really incredibly difficult, tough decisions that I preferred as a lawyer to just be the advocate, because you all are the ones that, and whether or not people acknowledge it or not, I know you lose sleep over decisions you might have, whether you're in the criminal arena or the civil arena. Very, very difficult role. So I was a criminal defense attorney for 13 years in a very small practice in Indianapolis, then became the U.S. attorney during the Bush administration from 2001 to 2007. And I just have tremendous respect for your association and for the work you're doing. I don't see Judge, is Loretta Rush in the room? Was she here? Okay, well, very close friend. I've admired her career, and she's been a leader on behalf of judges in the country and an incredibly strong voice for what your role is in this opioid fight. I will tell you that from the time I was a criminal defense attorney, most of my clients, many of them, had a substance abuse issue. So I learned from 1985 until I left that practice in 97 to become deputy mayor, and then working in the U.S. Attorney's Office fighting drug trafficking organizations, that truly the substance abuse problems in our country, and just having come from this hearing, they far outweigh other countries. We have the majority of the substance abuse problems in the world, particularly when it comes to prescription drugs and opioids. And so I've seen how they've devastated families, individuals, their lives, their children's lives. But I will tell you that nothing, and back then, when I was what I used to call a baby lawyer, or I now call a baby lawyer, a young lawyer, in the 80s, it was really crack cocaine. Then it kind of morphed to meth. That heroin has always kind of been in the background. Cocaine was always there as well. But I don't think we have seen anything at all close to what we've seen with the deaths from opioids and with the deaths because of the fentanyl. And so I'm really pleased to share with you, we just had a hearing where many of the law enforcement agencies that are dealing with the fentanyl issues testified. DEA was there, CBP was there, postal inspectors were there, and then Homeland Security investigation was there, ONDCP, and FDA. FDA, you may or may not know, is now embedded at international mail carrier locations. So our law enforcement agencies are trying incredibly hard to intercept the fentanyl, because that is in large part what has been killing people. And keeping in mind that it also, if any law enforcement or anyone in that chain comes into contact with it, they can die or overdose. And so we just had a very good hearing on that. But you all see it better than most. Every 15 minutes, a baby is born addicted to opioids. I have visited, and I suggest you all visit if you've not visited a NICU at a hospital. It's a very frightening, incredibly sad scene to see a baby detoxing. But then I've also been to recovery houses where, you know, the moms, hopefully they got into the recovery house before the baby was born, but sometimes they don't, and they get there after the baby is born. They're sometimes with their other young kids, and it is those kind of services that we have to provide. I remember when I was what I call a real lawyer, you know, trying to find help for my clients, all of those places were always full. There were always waiting lists. There were never enough treatment centers. There were never enough detox centers. There's never enough. Now, we've done a lot. We've put billions of dollars into this fight through the Support Act, through 21st Century Cures. We're doing a lot together. And I just want to thank all of you, because I know, and Loretta shares with me, that often the judicial system and judges and your role in this fight in the crisis is not really elevated to the extent that it should be. And so I look forward to hearing from you. And I co-founded a civil legal aid caucus, and you know, legal aid is doing a lot in this space as well. We've gotten a lot of reports from their work, and I look forward to any outtakes and reports from your work and ideas that you are all working on. I'm really proud, and I'm going to close with this. A fairly new and younger judge in Grant County, Indiana. Are there any Hoosiers here by any chance besides Loretta? Grant County is between Indianapolis and Fort Wayne. Judge Dana Kenworthy started a family recovery court. Okay, a family recovery court. And so rather than looking at it as the criminal defendant side, the child welfare side, they're bringing the family in with casework together. So focusing on parents getting into recovery, reducing the time children are spent outside the home, working with partners across the community to help the whole family recover. Now, they had a very active substance abuse task force in that county, led by the hospital, the local hospital, that after the first year, Marion General had reduced prescriptions by 100,000 written. Okay, think about that. So they all owned the problem. The hospitals, the providers, law enforcement, the courts. And I was really proud of this young judge, Dana Kenworthy, for her innovation in starting family recovery courts in our state, and it's been a model. So thanks for being with us today. Thanks for all of your work. We're all working together on this, and I look forward to studying more and then championing more what you do. Thank you. Thank you. Thank you. Thank you.
Can you hear me? I'm going to sit, because our panel is going to kind of take over the helm here and talk a lot more about some of the issues that we're seeing with opioid addiction among women and children. And I'd like to start off, we've heard a lot about the epidemic, but I wanted to start off asking a little bit of Dr. Pinnels, if you could give us an overview of how the addiction among women has been impacting families and how it also has an impact on community behavioral health, inpatient care, forensics, correctional settings, emergency rooms, and court clinics. That's a lot, but, you know, just kind of give us an overview, kind of set the stage.
Yeah, thank you very much. You know, it's a pleasure to be here. I'm very honored to have been invited, and thank you. Special shout out to extended the invitation today. Oh, sure. People in the criminal justice system, of course, there is an overrepresentation of people with substance use disorders and mental illness in the criminal justice system by far. When we look at people coming out of jails and prisons, we call that a matter of life and death because people are dying at extensive rates when they re-enter into their communities. So it's people coming in and people going out, and the episodes of care that need to be continuous during the period of incarceration. There are at least 80, the statistics vary depending on which study you look at, but we know with women that is the fastest growing population of people in the justice system. Statistics from 2012 say that there was a 646% increase in female offenders. And so this is an important area of need. Of those individuals, 2/3 are mothers. So we have to think about the whole family system. I worked in a women's prison for 7 years in the state of Massachusetts. I saw those women. I was always surprised, but then not surprised, which was terrible, to see that some of those women were incarcerated. Their cellmates were their mothers. Their cellmates were their sisters. There were family systems that were hugely impacted. Their kids weren't visiting them. There were always issues about how to extend the family, to think about the family network. As a psychiatrist treating those women, it became apparent that we have to look at the whole system and the whole family. The number of children with mothers in prison has doubled since 1991. So those statistics are huge. The proportion of people with substance use disorders, again, those studies vary because it depends on how they count substance use disorders and how they count mental illness. The more broadly you define substance use, the more broadly you'll see figures like 80% of the people incarcerated, the women incarcerated, have substance use disorders. One thing to note is a lot of correctional systems look at have data to say how many people are, let's say, on the open mental health case list, which means that they're receiving some form of psychotherapy, many of whom, but not all of whom, might be receiving what we call psychotropic medications. Correctional systems haven't historically tracked fully in their data sets how many people have opioid use disorder, for example. So when we received our SOR money in Michigan, one of the things that we started to work on was how do we track our prevalence rates of people with opioid use disorder? It was kind of assumed that a lot of people had it, and so it wasn't really clear how many actually did. And so one of the first things we have to do is good screening and assessment at all levels of that sequential intercept model of understanding what those prevalence rates are. So these are huge issues. There's a huge workforce challenge. Workforce needs are tremendous. We don't have enough professional workforce working in corrections, working in the justice system, working in courts, in terms of the licensed clinical professionals who can work with this population. So we have to address it on a number of fronts. And I'll stop there. I could say more.
Thank you. Dr. Jones, tell us a little bit about the difference in the way women experience substance use and addiction and treatment as opposed to men, and also their transition from substance use to addiction more quickly than men. Just talk a little bit about that phenomenon.
Sure.
And
So-
also how it translates to treatment considerations for women and children.
Yep. So we know that there are differences in gender in terms of how women initiate substance use, how they get caught up and stuck in substance use, and then how they have a chance to recover from substance use. So one of the things in terms of women versus men is there's this thing called a telescoping effect, and that occurs for alcohol to cocaine to opiates, whatever substance it is, you can look at it. And on average, women start using substances a bit later, at a bit older age versus men. But then when they enter into treatment, they tend to have a shorter period of duration of use before they enter into treatment. And so I've often wondered, why is that? And I think in part because it's women's roles in society. We have a much harder time hiding from society, and we get much more stigmatized and discriminated against. And that leads us to be caught up in various systems, child protective service systems, your court systems, things like that. So that's one thing. How do women initiate into substance use? We have very good data to show that on average, again, a broad brush generalization, not speaking for every woman or every man, but in general, women end up starting substance use in some type of intimate partner relationship. That could be a parent. That could be, I've had women tell me that they started using heroin at age 7 because their mother shot them up, so then they could be abused, sexually abused, right? I've had, on average, men tend to initiate substances in a peer relationship. That's not everybody, but that is sort of the general. Once women are actually into substances, it's a man's world. So oftentimes the women that I've had come into my treatment program at UNC as well as at Johns Hopkins will tell me, I violated every single thing I held dear to me. I broke every promise I made to myself. I violated every value I hold dear because I needed to have that substance to survive. And they had to do things in order to get that drug from the man. And their family members were often telling them, you know what, lady? You know what, kid? Your body is your pocketbook. That's the only worth that you have. So what do? You sell the only thing that you have. In terms of recovery, one of the things we see between men and women is that for men, you can take things away from them. You can take their family away from them. You can take their job away from them. You can take their house away from them. Most of the women that we see have already lost everything. They have absolutely nothing left that you can take away from them. So it's our job to build them up. And so taking a single gendered approach is incredibly important for women, because if you have a mixed gender approach, and I know that that's the reality for many treatment programs, the likelihood is that the man who's sitting across from her probably has had sex with her or raped her or some kind of challenge, interpersonal challenge between them. And so in mixed gender settings, women are less likely to talk than are men. And so what we know is that in mixed gender settings, men are more likely to get better. In women-only types of recovery centers, women are more likely to recover. And women need help with transportation and help with childcare as some of the biggest barriers, as well as housing. Thank you.
So we're going to come back to you because there's still a lot more to talk about along those lines. But I did want to get to Mr. Tennis and ask a little bit about the court system and how the court system is impacted on the family and criminal side. And why is it a health crisis? What treatment do we have available to judges? And what could they consider when they're really looking at this issue in their courtrooms?
Sure. Well, untreated and undertreated substance use disorders drives most of the crime problem. Before I begin, I want to say I just left the conference for the National Association of Drug Court Professionals, where they are training. It's the largest gathering of criminal justice judicial personnel ever in all of world history, really, to be trained in how to identify those with substance use disorders and get them the help they need and use the judicial system to do the very work. So if you're not involved with that group, I encourage you to do that and to support them in any way they can. What they are doing is miraculous, transformational work. So it's such an honor to be involved with them. I was a prosecutor for 26 years. The last 20 years I did more legislation and policy. But as a prosecutor, I can tell you, and someone working in criminal justice policy, most of the crime problem in our nation is a direct consequence of massively failed healthcare policy. The Surgeon General, the current one and the one before, this is a bipartisan issue, have identified that treatment resources are about between 11 and 15% of what's needed to address the substance use disorders in our world. We have an arbitrary rule, for example, used to be that Medicaid would not cover residential rehab at all. Now it covers up to 30 days, and that's going to go away, scheduled to go away in a couple of years. Many of the women, particularly, that we're dealing with have suffered severe trauma. It's as it's been indicated, the stigma that exists for drug and alcohol addiction in general is more severe for women, and it's even more severe, again, for women with children. And you can see that reflected in the policies that we have. Women are more likely to have suffered sexual assault and trauma going into treatment. And when they deteriorate, the ones that are the sickest, the ones that have become homeless, that have lost their connections to their families and their work and their children, are the ones most likely to be incarcerated and die. They're the ones who we know need, based on NIDA research, they need probably start off with a minimum of 90 to 180 days residential rehab, and yet Medicaid won't pay for it. It will pay for the brain surgery you need. It will pay for the cancer treatment you need. Substance use disorders, no, it won't pay for it. So there has been a temporary fix for a couple of years saying we'll cover up to 30 days. But if you need 90 days and you're released at 30, that can be a death sentence. You're likely to relapse, very likely to relapse. And when you do, if you've been on drug-free treatment, you're likely to fatally overdose. So
talk a little bit about also the other collateral consequences of the treatment ending in those 30 days for women in terms of housing and the like.
Well, they're likely to, first of all, if you some places just either they find special sources of funding or they fundraise, nonprofits will fundraise in order to get women long enough treatment. But there's actually even a HUD rule, it's a regulation, Housing Urban and Development rule, that says if you go from day 90 to day 91 in residential rehab, you are no longer deemed homeless and you lose your eligibility for public housing. So the clinician and the client and everybody working with that woman might know, or man, might know, this woman needs another 60 days in residential rehab or she's not going to do well. Your choice is either continue the treatment and give her what she needs, and have her lose her housing and become homeless again, or have her leave prematurely before she's ready in order to maintain her housing. So those are, well, I call this stigma-skewed policy. We need to be strong. I mean, the short-term funding solutions are good, but you cannot build treatment infrastructure on funding that's going to go away in a couple of years. To build a treatment program, you have to fight zoning, NIMBY rules. That can take a year or two. A lot of money has to be invested. Medicaid should treat substance use disorders the way it treats every other disease. You should get what you need, and it actually will save the Medicaid system money. The research shows you reduce physical health care costs by $4 to $5 for every dollar invested in substance use disorder treatment. Think Hep C, $70,000, treating HIV for a lifetime, other liver diseases and other system failures. This is not only fiscally unsound, it's really cruel and inhumane that we would not cover this disease. And instead, I mean, actually, we should be going upstream. We should be treating people before they ever get involved with you. Doctors should be trained to identify the disease, and we should have the treatment resources to take care of them before we even get them. God bless you all, and God bless NADCP and the police groups that are doing interventions now, and the warm handoff work in ERs, but everybody consistently says we have got to have more treatment, and that funding has to be permanent. It has to be part of Medicaid.
Dr. Penose, talk to us a little bit about the prenatal impact of substance use, and particularly opioid use, and the prescribed treatment for pregnant women, and how pain is managed for cesarean births and all those things and the implications there.
Yeah, so there's a complex interrelationship, obviously, and part of how we started in this crisis was the management of pain that then led to addiction. And there's been a tremendous amount of research that's come out now that's taught medical professionals ways of prescribing that are very different than what I learned when I was in medical school in the mid-1980s. For a generation of physicians, when people had conditions where pain was involved, you basically prescribed as much opioid medication for pain relief as your attending physician taught you, and it was kind of like what they learned, and it was sort of kind of made up, really. Mm-hmm. And so whether you would get a 30-day supply of pain medications for a procedure or not kind of depended on basically what you were used to. More and more studies are obviously working on showing how certain types of conditions, including pregnancy, childbirth, orthopedic procedures, dental procedures, that the amount of pills really don't need to be as extensive as they were. And in fact, what we've learned, what some of our researchers at University of Michigan say, is it's called the French fry effect. If you order a supersized French fry, you'll eat more French fries. If you get more prescription for pain pills, you'll take more pain pills. So if you can reduce the number that you require, then that is you'll end up actually taking less. There is pain management that is still necessary, and we cannot ignore the fact that you can have better outcomes if you appropriately manage pain. So there's a lot of education that needs to happen in that space. In terms of mothers, pregnant women who have opioid use disorder, there's a lot of research that shows that pregnant mothers who have opioid use disorder, for that baby, that methadone or buprenorphine is very important to prescribe for those pregnant mothers, which creates a lot of controversy for people that are sort of lay people, because then it seems like you're prescribing a medication to treat an addictive medication to treat an addiction, and then you have babies that are born that have to go through some type of withdrawal management, and you heard some of the impressions about what that looks like. We are learning a lot more about what helps babies remain safe and how they can be safely managed if they are born having been exposed to opioids in utero. And you work in the OBGYN department, so I'm sure you can speak also about this. But it's really important that we combat stigma around this, because you can risk the baby more by not treating the opioid use disorder appropriately. The other piece that we have to remember is that what we're learning a lot about keeping families united together with safe plans of care. That's really critical. So where you do have a baby born to a mother who's had opioid use disorder, you want to make sure that that mother and that child and any other children in the home have a safe plan. And so that reunification and keeping the family whole can help that baby who's born, get with the appropriate supports and the appropriate safeguards, get the care that they need. When a mother is incarcerated, that is an ACE factor. I don't know if you've heard about adverse childhood events, but that is an ACE factor for that baby. So when that baby grows up and takes that ACE survey, they will score 1. And we have to be really mindful about trauma at all ages, trauma prior to the age of 18, these adverse childhood events. We know that for incarcerated women, only 20% could report that they had none. 34% or more had 5 or more ACE factors. Any one of us in the room, the general population, would score maybe 1, maybe 2, but the incarcerated population has 5. That's or more. That's huge numbers of pre-18, prior to the age of 18, adverse childhood events, which includes neglect, abuse, and separation and conflict in the family home. So these are really important, because the more ACEs you have prior to the age of 18 in those critical developmental years, what do we do when babies cry? We hold them, we change their diapers, we feed them. These are children that have not had those experiences or have had less of those experiences. We know that if you follow them developmentally, they will be at risk for death, they will be at risk for incarceration, they will be at risk for high-risk behaviors. And so we have to get upstream again at this multi-generational issue and think about how do we help those pregnant mothers who've already succumbed to opioid use disorder and help those babies get safe plans of care. I don't know.
Dr. Jones, can you talk a little bit about the polydrug use and the impact on women and children and treatment issues that are associated?
Absolutely. So I know that the opioid epidemic or crisis has just consumed our nation. At the same time, as we heard earlier, there are many other substances, and I want to say something about alcohol. Because I think a lot of times what happens when we talk about pregnant women, that there becomes this assumption that if the substance is illegal, it must be worse than a legal substance, when in fact it's actually not true. The 2 substances that we know the most about are tobacco and alcohol. And alcohol in particular is the substance that we know the most about in terms of fetal alcohol spectrum disorder. So that means that on the very severe end, babies can have structural changes to their face and to their brain if they've been in utero exposed to a lot of alcohol, high quantities of alcohol. With our other types of substances, while I'm not saying that they're good by any means for a mother to consume, the data that we have talking about the associations, the relationships between prenatal exposure and cocaine or opiates and things like that is much less. So obviously we want to have a very healthy pregnancy. So we want to help support our moms to stop smoking. We know that smoking cigarettes in and of themselves can make the neonatal abstinence syndrome that we see when moms deliver their baby and the baby goes through, if the baby goes through withdrawal, and not all babies do, but if they do, we know it can be much worse because they were smoking. The more cigarettes they smoke, the worse the NAS can be. So that's a really important message to help support our moms on how they can cut back with their tobacco. We also know that it's really important that the neonatal abstinence syndrome, that severity of withdrawal that we heard about earlier, that can be so easily managed in the hospital if the hospitals have good tools. We have great tools to assess it. We have good medications to treat it. And we have this whole new paradigm called Eat, Sleep, and Console, where it's been a whole hospital paradigm shift, where moms and caregivers are actually engaged in the care. Babies don't have to go to the NICU just because of the withdrawal, they can be managed in the hospital. And we've been able to drastically reduce the length of stay babies are staying from like 30 days to 5 days on average, and greatly reduce the numbers of babies that need medication after they've been born. And we have healthier and happier moms. So there's a lot that's going on this front that we can do as healthcare professionals and that you all can do as judges to really understand what's best for mom and best for baby together, rather than pitting baby versus mom against each other.
That has implications legislatively. Can you talk just briefly a little bit about some of the legislative challenges that can bring in terms of charging women who have, addiction and
Right.
also are pregnant?
Yeah, so one of the things that we know is that oftentimes we have to rely on a positive urine and to make life-changing decisions, and I think you all have such an incredible job. I think our child protective service workers as well as our judges are making life-changing decisions for people. So keeping in mind that just because there is a urine that is tested positive, please don't just stop with that. You need a whole host of understanding risk factors. There's data now to support blinded CPS removals or child removals. And we know that when the whole team is blinded to race, demographics, other types of characteristics, housing status, that particularly for children of color, that it's dramatically reduced in removals from 57% to something like 21%. So we all have our own sort of perceptions and biases that we come into any situation with. So I think that in particular is really important. It's also important to remember that a urine positive test is not a parenting test, right? It is not a diagnosis for a substance use disorder either. It is one piece of information that needs to have context around it to really understand what's happening. We've had women that have had their children removed from their care based on one positive benzodiazepine test. And she had to work for 2 years to get her child back. So we need to have a much more thoughtful approach to really understanding the whole risk ratio of what's going on, and then for moms.
Mr. Tennis, talk a little bit about that particular issue and the implications for a coordinated approach, family-focused approach, and also the intersection of the child welfare system and other systems in this issue.
Before I begin, I think that you all have available to anybody here, there's a directory that was put together by Volunteers of America and Wilder Research, funded by Annie E. Casey Foundation. And this is a family-based residential treatment programs throughout the country. I highly recommend you have a look at any that are in your area to see if they're a resource for you. I remember meeting early on with when I became secretary of our Department of Drug and Alcohol with Deputy Secretary Bev Macarath for Children, Youth, and Families. And I came in prepared to tell her that 60 to 70% of her cases were mine, that these involved substance use disorder, and we needed to think about how to keep the family together and work together. And before I sat down, she goes, I think about 90% of my cases are yours. So and we have some attorneys in the room that I had a brief chance to speak to, and they said the same thing, that substance use disorder is driving all of this. We know that the foster care system, that the outcomes for children placed in foster care historically have been abysmal, that they are likely to, they're just an extraordinary high risk of ending up being criminal justice involved or addicted to substance use disorders and suffering a premature death. I think the challenge is really what we're trying to do is seek legislation. We actually, my group, the National Alliance for Model State Drug Laws, has a law that we did back with the President's Commission that we're updating called the Family Preservation Act. And it creates a presumption, it directs the judiciary, whether it would be, or child protective services workers, whether it's in the criminal justice system or the family court system, to first look and see about keeping the family united and see about keeping them, in something like if they do think that it's more supervision is necessary, it should be based on a clinical decision, but to see if some of these family-based residential treatment programs would be appropriate, clinically appropriate for these individuals. They have extraordinary success rates. Children, the recent Children and Families First federal legislation now will allow for the payment of the children. It used to be they had to those programs had to eat those costs or come up with some other way to fund it. But now that will be paid for. But again, I know I sound like a broken record, and I am. The IMD, the rule that says Medicaid won't pay for what you need for treatment does end up meaning that the funding is there just isn't adequate funding. You can't build the infrastructure on this. If the funding were available, if there were a permanent source of funding that said this will be based on the clinical need like we treat other diseases, whether it's an MAT appropriate case or another kind of treatment appropriate case, we should treat this like we do other diseases, and it should be based on the clinical assessment and what's in the best clinical interest of the client.
Now, we haven't really explored too much the public education realm. I'm going to open it up to the panel, anyone to talk a little bit about public education and prevention and what kinds of things we might want to consider around prevention.
Well, we know what works in prevention. There are a lot of things that we know, although they're expensive, we know that the nurse-family partnerships are an extraordinarily effective intervention where the resources get to the moms early on. But at the student level, there are K-12 prevention, drug and alcohol abuse prevention programs that are tremendously effective. And I don't have any interest in any particular ones, but I know I had an offer from University of Colorado's Blueprints Foundation to offer Botfin life skills training for 6th, 7th, and 8th graders. A huge body of research showing a 60 to 70% reduction in drug and alcohol use, as well as violent behavior and other high-risk behaviors as well. I sent something out with our Secretary of Education to all 500 school districts and only got 50 replies. And everything that was offered was for free, including paying for in-service days for teachers. We need to, when we redo our model state law, we're going to put more teeth in it and basically say we're going to have to nick you on your funding. But K-12 education works. Student assistance programs, or sometimes what's called SBIRT, or screening, brief intervention, referral, treatment, that's normally in the medical model, can actually work in the school setting to identify kids early at risk and wrap the necessary resources around. We can spot the information is there, the knowledge is there. We know how to spot kids before they get too far down the road in misusing substances and heading into the juvenile justice system. But we don't really resource it. We used to, but the federal funding went away. It used to be funded by federal safe and drug-free schools funding. That money got cut when we did what was the one that was going to drive all the academic, No Child Left Behind. We were going to make sure everybody knew about the European 30 Years' War in the 1600s. Much more important than keeping them healthy and prosperous. Sorry about my cynicism, is probably not well articulated here, but I think the research is out there about what works in prevention, and that's actually the most, it takes longer to see the benefits, but in terms of leaving a legacy for posterity, that is something that really is one of the most cost-effective ways to reduce the problem.
So we can talk a little bit about best practice, and I'd like any of you to talk a little bit about some of the areas that you've seen to be successful, but I also want to hear a little bit about wraparound services and how successful they can be. So I'm going to open it up to the panel to have that discussion.
So I'll start. I'll give an example at the Center for Horizons, which is a UNC comprehensive care center. We have a dyadic care model, so mothers and children come to treatment together. It's an outpatient center as well as a residential center, and very luckily, we get to have our women and children live with us for up to 9 months. And that's one of the longest programs that I know of in the United States, and Medicaid actually does pay for it. So we can talk afterwards how we've done that. So we're very, very thankful for that. And so what the magic is, so our outcomes, let me start with our outcomes and then I'll tell you how we get them. So our outcomes, 95% of the women that leave our program, that complete our program, leave with their children. Cases are closed, children are, and mothers are reunified, families are reunified. Of our women, we have about 50 women every year that have babies that are born. That's at 5% low birth weight and 5% prematurity. If you think about untreated addiction, that's well in the high 20s. So we actually have tremendous cost savings. We're having healthy babies. And 77% of our women get jobs by the time that they complete our program. But it's not an overnight fix. That's 9 months. That is a lot of funding, but you have to put the work in because our women didn't develop their addiction and their severe substance use disorder overnight. It's not going to be fixed overnight. So it's an example of where you put resources, you get the results where you put the resources in. What I think the magic secret sauce of our program is our dyadic maternal child therapy that happens. So we have maternal child therapists that go into the home and they're there for mealtime, for bedtime, when those kids get up, when mom, whatever kind of stresses mom has, they're there to help them with it. Because moms, a lot of them have been in our foster care system. A lot of them have been from different types of broken homes. They've never had a positive parenting model. So when they're in your courtroom and you're saying, you need to complete this parenting class and do these things, a lot of times they don't know what that is and they don't know how. So you can tell them what to do, but please, please, please tell them how to do it. We have to scaffold for them so that they understand exactly what those steps are that they need to complete to do the things that you need to see to show that they're safe parents. So I'll stop there.
Any other?
Yeah, I'll just talk. Parent-child interaction therapies are. Oh, thank you. Parent-child interaction therapies are really showing some really great promise, and I think it's really important to think about again that system. I'll tell you about the wraparound program that you mentioned that we had developed this mission model. We used a lot with female offenders around reentry. We've used them in drug courts as well, and basically it provides a specialized case manager and a peer support staff worker who meet the person where they're at. We also try and incorporate criminogenic risk with behavioral health strategies because the behavioral health system is not adept at thinking about criminogenic risk. If you think about criminogenic risk factors, and judges working in criminal courts really understand this, one of the major criminogenic risks is substance use disorder. And ironically, that whole data set, that whole research, the foundation of the research of the criminogenic risks started with looking at people with substance use disorders who are in the criminal justice system. So it's so interesting to see that we're coming full circle in looking at substance use disorder as a criminogenic risk. But what we're trying to do is train the behavioral health workforce to understand how to work with the criminal justice involved. Because what we see is people in treatment programs very often, and this includes women and men, will get arrested out of treatment programs. They will get thrown out of treatment programs. They will get behaviorally disruptive in a waiting room of a primary care provider, and they'll call the police and they'll kick them out of treatment. Well, why were they behaviorally disruptive? Maybe it's because they have trauma histories. Maybe it's because they have intolerance to being controlled or being told to wait because they've been made to wait in some traumatizing situation. And it's not to say that it's the abuse excuse. We've moved past the abuse excuse kind of framework for criminal justice reform. We've started to think more about not that you should be excused for misconduct, but that we should understand where trauma fits in to those challenges. I'll also say, just this morning, I read a study that was done by the Michigan Department of Corrections, and I sent a kudos email to the director, because they did a study looking at the correctional officers and their own trauma histories, their own challenges with behavioral health conditions, suicidality amongst correctional officers, law enforcement officers, substance use disorders amongst our public safety officials, and I dare say some of the trauma exposure that judges have in their work are not to be ignored. And so if you can treat the trauma and be compassionate and think about your own workforce as a traumatized population, you can better provide, and this is true for the healthcare professionals too, I will say. My court clinicians, when I ran the court clinic system in Massachusetts, they couldn't see success because they always saw the treatment failures, because who else comes into court but the failures of the treatment system? And so how do you train your workforce, your professional judicial workforce, your lawyers, your clinicians that are consulting to the judges and to the law enforcement professionals about how to see where success can lie when you haven't seen it yourself. So dealing with the trauma of the workforce, dealing with understanding how success can actually what success can look like, kind of changing your definition of success and looking at small wins really helps. And some of the wraparound services that we've been providing through this mission model have really helped us look upstream at those workforce issues. We do reviews. You're going to have workforce that deals. Our wraparound service providers are used to failures. They see death. So what do we do when somebody that they're in their system that they're treating has just died from an opioid overdose? We do consultations related to that, try and support them in dealing, because they have to keep going back out there and support the 25 other people that they're supporting and help deal with what the impact of that death is on that whole system. So I would say looking, again, more broadly and holistically, and trauma, I've really become, as much as I've dealt with very high-risk individuals who've done some very heinous things and put to the public, I've really started to look at the world from a trauma lens, and I think it helps in terms of providing services.
So on that note, I'd like one of you to talk a little bit about the implications of co-occurring disorders, particularly mental health and polydrug use and the opioid, substance use issues.
I'll make up just a preliminary comment, which is in thinking about co-occurring disorders, to maybe distinguish between co-occurring severe mental illness versus, I think most people with substance use disorder will have anxiety disorder. It kind of comes with it, or some levels of depression, and maybe justifiably if they've lost their job and they've lost their family and they're homeless or they're committing crimes. So some of that cleans up with ordinary substance use disorder treatment, but as you start to have more co-occurring severe mental illness, whether it's schizophrenia, bipolar, or dissociative identity, other things, then I think you're really talking about a very significant difference in the way you handle the care.
Yeah, I just want to say there's this distinction between serious mental illness and mild to moderate mental illness and sort of the payment models that go into treating them. The problem is, and having, again, worked with many, many women who have substance use disorders, who have these kind of mild to moderate anxiety, depression, whatever, all of those things can be really impairing. Even though we don't call them serious, they can make a person not be able to get out of bed to show up for their probation appointment. They can be impairing in the sense that they don't want to take the bus, or that they have a hard time changing the diapers of their children because they can't get out of bed. And even though they may not look serious in the sense of the public mental health system funding that, they may need some services that they are reluctant to obtain. There's also a lot of stigma for people with substance use disorders. There's not a lot of appetite also for saying that you also have a mental health condition. Similarly, for people with mental health conditions, there's stigma to having substance use disorders. So we're trying to work a lot with people with lived experience with these conditions, and some who have crossover, the co-occurring conditions, to use peer support as role models for what can be success. And just in terms of healthcare providers, historically we treated these things serially. You had to get sober from your addiction before you could treat the depression. We don't believe in that anymore, but the problem is you do have treatment programs that will say you have to be off all psychotropic medications to be in this residential program. Well, if you need some kind of medication for your depression or some kind of medication for your anxiety, you shouldn't have to be off it to be in a substance use treatment program. That's kind of old school, that it has to be serial treatment or sequential. It should be simultaneously treat the person as a whole, just like we do with their physical health care conditions. You don't take people off insulin to get them into a residential program. You shouldn't have to take them off their antidepressant.
So that kind of leads to that single port of entry for treatment. So it's not a one door for substance abuse and one door for mental illness necessarily, but the single door for treatment for any behavioral health issue.
Yeah, and I think hopefully we're moving beyond the co-located model to truly integrated model, where we've got hand-in-hand in partnership psychiatrists that are trained in addiction, as well as other types of co-occurring disorders that are as a specialty, that you've got with our peer support specialists. I hear a lot, and I think they're absolutely fantastic in terms of extenders of treatment. The one thing I would say is that not all peer support specialists are the same, and they also come in with their particular biases. And so be very careful if you're doing anything around peer support specialists, because we've had, there was an example in the emergency department where all of the individuals that had opioid use disorder that qualified for buprenorphine were being placed on buprenorphine, and then the peer support specialist was saying, oh, no, that's really bad, and then taking them off of it, and then you had overdose situations. So just make sure that you understand that the roles of the peer support specialists and that they have good training. In terms of severe and persistent mental illness and being pregnant, I have to say that is probably among the most marginalized populations. We have had a number of women that have really severe schizophrenia or other types of severe and persistent mental illness, and trying to get them stabilized and appropriate care in this country. There are very, very few beds in psychiatric hospitals for pregnant and postpartum women, and so we desperately need greater access to services and more funding for that dual diagnosis of the persistent and severe mental illness plus pregnancy.
I just want to give one other mention to the population that's not talked about as much when we talk about SMI, serious mental illness, is the population of people with intellectual and developmental disabilities, which again comes under different agencies, different funding structures, a whole different framework. But ironically, the most common cause of intellectual and developmental disability is alcohol use in pregnancy. So again, if we could get upstream to that problem, we could potentially help stave off a whole host of issues. But we are seeing larger numbers of people with IDD in the criminal justice system, and it's often under-recognized and it's not screened for, and so we need to be aware of that as well.
And to add to that, then those individuals who are in substance use disorder treatment end up failing substance use disorder treatment because we're using these fancy cognitive behavioral therapies that are not appropriate for individuals that have IDD that could be FASD.
Those are excellent points. I'm going to interrupt our panel for just a second. We'll get back to them, and I'm going to invite Congresswoman Custer from New Hampshire to come forward. We're so happy to have you with us. Thank you for joining us.
Thank you so much. And can I just put that down? Is that appropriate? I apologize for interrupting the conversation. It's fascinating. I'd love to have been here all day. Excuse me, our votes are about to be called, and so I will have to leave. But I want to just say I concur with everything I've heard in the last 5 minutes. Thank you for everything you're doing. Just anecdotally, well, let me get into my story and then I'll tie it back. But I'm Congresswoman Annie Custer from the 2nd Congressional District in New Hampshire. I'm an attorney, I'm an advocate. I was elected to Congress in 2012. And New Hampshire is one of the hardest hit states in the entire country in terms of the opioid and now fentanyl epidemic that we have. And so I just hesitate to dive into the middle of your conversation, but want to share a few things that we're working on here in Congress, and we'd love to get advice from you as we go forward. I am the founder and now the co-chair of something that we call the Bipartisan Opioid Task Force. We started out the heroin task force, now it's just called the Opioid Task Force, and soon with methamphetamines we're going to have to open up the name even more. And we had, at our high water mark, 105 members of Congress working together last cycle, half R's, half D's. We have fewer R's this time because so many of them lost their reelection, but we are working in a very bipartisan way, and we were instrumental in both the CARA 1.0 and the CARA 2.0, getting funding out to the communities, getting the focus on education and prevention, access to treatment, and then long-term recovery, recognizing that this disease changes the brain and that the recovery takes a long time. And unfortunately, historically, relapse has been very frequent, high probability. What I was going to say is that as I was into this now, I've been in Congress 7 years. We've been working on it from the beginning. But 3 years into that, I'd created the task force. I was doing legislation, getting funding. And my own brother out on the West Coast, my older brother, he was 68 years old, had a series of hip surgeries, was on high doses of OxyContin and oxycodone from September to April. And by May, our family was in the midst of an intervention to get him into treatment. And now we are 2 years, we collectively, because we're living it the way every family is, in successful recovery. But one of the points that you just made hit so close to home, because he's 3,000 miles away, so luckily we have a big family. We were taking turns flying out there, and first of all, the recovery from the surgeries, and then second of all, trying to help him get the resources that he needed. And so we were working with this amazing retired specialist that was helping us navigate the system, and he had a great deal of faith in her, and she was helping us to navigate the family and getting him into treatment, and trying to work with the surgeon. And that in and of itself was a mess, because the surgeon wanted nothing to do with the addiction, and the addiction specialist wanted nothing to do with the surgery. But then when we got right down to it, he came out of recovery, and I'm on the phone with him, and I know everything about medically assisted treatment, and I'm all into the buprenorphine and where he can get it and how he can get this done. And he said, oh, no. This person advising him had said, you don't want to trade one drug for another. And I'm like, no. Yeah. And so every day we live this, because he is in a just say no recovery of abstinence. And he goes to his AA, and then he has to drive over the mountain to go to his NA. And we have our fingers crossed. So it would be a lot easier for the rest of the family if he had followed the medically accepted practices. But in any event, what I wanted to talk briefly about is how we are addressing this in New Hampshire and some of the innovative solutions that we've come up with, because it does have everything to do with our judicial system. In one of our counties, this was one of the first hardest hit. It's called Sullivan County. It's a small rural place on the Vermont border. And Vermont was hit very hard. The drugs were coming up Interstate 91, if you've ever traveled in New England from New York. And this little teeny county realized they were going to need a brand new prison with 200 beds. And they couldn't possibly afford that, nor was that the direction they wanted to go. And so the warden and two of his employees said, we need a different approach. And they literally put together a program. They built a much different facility. I think it looks like a little boarding school. It has bedrooms, it has classrooms, it has a cafeteria, it has a gymnasium, does not have any bars on the windows. And they brought the treatment in-house during incarceration. And they brought in the medically assisted treatment, they brought in the AA and the NA, they brought in the mental health treatment, because in our criminal justice system in New Hampshire, and I think this will play out across the country, we have from 80 to 90% co-occurring mental health disorder and substance use disorder. As an aside, we ended up starting a whole nother task force on ending sexual violence. Let me just say 100% of the women in our state prison are survivors of sexual assault. So that is coming up more and more and more frequently as I talk to people that are trying to cope with their addiction. But also, I do a lot with veterans, so we have a lot of PTSD, depression, anxiety disorder, et cetera. So trying to address the co-occurring illness, we were bringing the mental health treatment, both individual and group therapies. One of the things that he said to me when he started the program is the one thing they do have is time. And everybody jokes, but he said we have a very low no-show rate. And in New Hampshire, it's actually very difficult to be in recovery. If you're working, if you have kids, to find the time every evening to have gas in your car and snow tires and drive over the mountain and get to your treatment or get to your AA meetings, that's hard to do. And so, given that people have time and that they were willing to use their time constructively, and particularly that we could get at the core mental health issues that they were self-medicating for, we ended up, this little teeny county ended up, in my view, changing the world, which is, I'm trying to make this a model. We dropped the recidivism rate from the 80th percentile to the 20th percentile. And the key was they stayed with everybody for 1 year after they were released. And it's a small county, it was a small number of people, so they tackled every barrier to successful recovery. Can we help you get a vehicle? Can we help you get a job? Can we help you get job training? Can we move you to a different community because of the bad habits or the bad influences? Can we get childcare? And just by approaching it in that individual way and helping them for an entire year to stay on track with their recovery, they've had fantastic results. So now that warden has gone to a different county, Merrimack County, which is the capital of Concord, and he's implementing that there. And other counties are taking a different approach, but the whole idea is bringing the treatment in-house. We also have drug courts for people who don't go into incarceration at all. But let me close by saying this is a aha moment that has nationwide implications. When I started to look into this and try to find out why we're not approaching treatment during incarceration, I found out that it is because 50 years ago, Congress, before I got here, made a decision when Medicaid became the new program that there would be an exclusion for coverage during incarceration. To give people the benefit of the doubt, I'm guessing that they assume that there will be an infirmary. If you break your arm or you have a headache, we will help you out. But multiply that forward all across this country, and whether you're talking about crack cocaine or marijuana or heroin or opioids or fentanyl, all across this country, all of the people that have been locked up have been denied access to mental health therapy and substance use therapy. I want to change that. My legislation is twofold. Our first bill is to bring medically assisted treatment into during incarceration. It's a grant program. Programs can apply, and we can start the process to create the data to be able to demonstrate that this is successful. My second bill, which is a heavier lift, and I would love your help, is to remove the exclusion for coverage for health care during incarceration. There's absolutely no reason all across this country why people, the day they go into incarceration, when they would need the most services to help them turn around and be productive and get their lives back on track, and to leave with job training, a healthy record, the skills to manage their lives, and the health care to go forward, both mental health and substance use. And what I'm hoping to prove, and I'm working with Dartmouth Medical School and some of the people there to try to create the data and the research, is to demonstrate to my colleagues that the long-term impact is that we reduce the census in our prison population all across this country dramatically, and that the resources that were otherwise spent would then go into productive living, successful living, and turn people's lives around. And so I'm working with colleagues on both sides of the aisle. I'm working with colleagues from every different background and community. My colleagues at the Congressional Black Caucus just about cry when I tell them this, because they've lost an entire generation of people to incarceration without any kind of treatment or services. And I just think we can change the world this way. And if it is any indication, we now have two headlines in the last month, one from a jail called the Valley Street Jail in Manchester, New Hampshire, that is our toughest jail in the state. They have gone to the city officials to ask for less funding next year because the census has dropped dramatically, because people have been diverted into drug courts, mental health courts, veterans courts, and getting services in the community. And likewise, Rockingham County was in the same situation. They have lower census and asking for less resources. So anecdotally, this approach will work. I'd like to see it work all across the country in every community. This is a public health crisis. It's not a criminal justice crisis. And I'd like to turn that around and get people back to their families and back to their communities. So thank you. I appreciate the opportunity. Thank you for everything you're doing. And I'll go vote.
Thank you so much.
If you want further information, this is Marissa in my office, and you can find us at custer.house.gov.
Thank you so much. Appreciate it. We're running close to the time to close, but I want to be sure that I encourage you, Lavina, I guess we're still doing the cards from the participants. If you have any questions, we'd like you to write them down on a card. Or do we have a card? If not, you can just raise your hand.
We don't have cards.
Okay, no problem then.
If anyone have a question,
Yeah, you can raise your hand then. Okay, so we'll continue because we still have lots to share. So we talked a little bit about before the Congresswoman joined us. We talked a little bit about the implications of co-occurring disorders, and you mentioned Dr. Jones' postpartum issues. Can you talk a little bit about postpartum depression and the implications for the epidemic?
Absolutely. So a lot of times, particularly if someone has had depression before they become pregnant, they're at very high risk for having depression postpartum. So we need to make sure that all women are being screened for it, and not just screened, but screened and then given the resources that they need. In addition to that, we have a crisis in this country that has not gotten as much attention as it deserves, and that is that we have our women within 1 year after giving birth dying at higher rates than the vast majority of other countries. And there's a whole host of issues, and particularly rural white women are at incredible risk for dying. And it's because of opioid overdoses. It's because of hospital deserts. We have hospitals in this country. I can give an example in North Carolina where all these little small community hospitals have gone out of business for obstetrics because the insurance and malpractice is so high, they're too scared, so they close them down. So now our women are driving in the snow and ice at least 3 hours over the mountain to the only hospital that is still delivering babies. Women are dying. They're dying in childbirth, and they're dying afterwards. So I think that we have to do a better job understanding the obesity epidemic, because we have many women that are obese and become pregnant, and they're not given the proper care that they need. We have bleeding problems it's not being treated in the hospital. And if you are a woman who is postpartum who has been using opiates, we have data to show that you are 4 times more likely to die in the hospital than your non-opioid using counterpart. And that's because our hospitals aren't equipped with having good ways of addressing active addiction in hospitals. If you talk to hospitals, you will hear them talk about women shooting up in the bathrooms and their partners shooting up in the bathrooms. And so we need more supports for our hospital and education to be able to reduce that.
What do you feel about MAT in correctional facilities? Have you all kind of discussed that a little bit? And can you talk about medically assisted treatment in correctional facilities?
Oh, this is a big issue right now, because again, we're talking about disrupting episodes of care. If you believe, the data suggests that if you have an opioid use disorder, there are medications to treat it, just like there are, by the way, for tobacco. Nobody quibbles over using some Chantix for their for their tobacco use disorder. So, but for opioid use disorder, it creates a whole controversy. We come up with these terms like medication-assisted treatment, which, by the way, there's emerging terms: medication for addiction, medication to treat opioid use disorder, or mood is kind of the new term because for a variety of reasons. But the idea is these are medications that treat the disease, and people might need them for very long times. These are chronic conditions, and so they might even need them for life. There's not, there's a lot of mixed research and complex data around how long people need to take these medications, so we try not to tell people, oh, you only need this for a brief period of time, because we know when you stop the treatment, you're at risk, much greater risk for overdose and death, especially if you stop the treatment abruptly. So the question is now, how do we make sure that when ignoring the walls that you're in, the jails or the prisons that you're in, that you're getting the right kind of health care that you need? And so there is a lot of work being done, and the federal funding from STR and especially SOR is really prioritizing the justice-involved population for judges thinking about this person that they're seeing in the court. When you might be sanctioning them for a period of time of incarceration, you need to realize that jail may not provide them with the medications that you want them to take. So there is a lift. You have to get workforce development. You have to get the jails and the prisons able to provide those treatments. There's a culture shift. There's a whole host of things that need to happen. But there are some success stories out there in this country that are emerging that we can have as models to develop appropriate medication use in the jails and prisons.
And just to add, so I'll give a shout out for Rhode Island because they've done tremendous work around their jails and having medication-assisted treatment and reducing the mortality rate. Because what happens if you don't have medication-assisted treatment in jails is Shabar in 2018 showed that former inmates have they are 40 times more likely to die than the general population of opioid overdose. And if you restrict it to heroin and restrict it to the 2 weeks after leaving an incarcerated an incarcerated setting, it becomes 74 more times likely to die. So without having medication-assisted treatment, we're killing people, potentially.
Just to add one more kind of an ancillary point, the research on behind-the-walls treatment is that by itself, it doesn't really get the job done. And you really need to make sure that you aim for a seamless transition out of prison-based treatment into community-based treatment of whatever kind is appropriate. I know NADCP is looking at, and maybe Tanya, I don't know, maybe has some going now. Reentry courts is kind of there are a lot of cutting-edge things that they're doing. One is the family treatment courts that you've been hearing a little bit about. They've been pushing that a lot, but making sure that the person comes out into community-based treatment is absolutely critical, and that's where the good outcomes come.
And just one thing, I want to give a shout out to, again, Michigan Department of Corrections, which established a policy so that affirmatively stated that people on parole and probation under their supervision would not be violated if they were in active treatment, which was really important because what we were seeing with this wraparound services, we were seeing people were afraid that they would be violated if they were prescribed methadone or buprenorphine and tested positive, that would create a violation. So they were reluctant to be on it. And so by having that policy in place and training the parole officers to say, we're not going to violate people if they're under the prescription of a valid prescribed medications for their opioid use disorder, and we're going to work with that as a policy decision. That was really key. And we're still working on educating the workforce around that. And the other inmates who influence each other in a way of saying, oh, you better not take that because you're going to get in trouble. And we really were trying to get again, do that culture change because that transition in care is so incredibly important.
And I don't think we've used the words recovery-oriented system of care, so I can't have the session end without saying that because it's so important. We have treatments. Treatments are not cures, right? There are treatments, and while people are in those types of situations and with those parameters, they do well. But to date, we don't have a cure. And so that's why we have to have funding and support for a recovery-oriented system of care, which being a treatment facility, we don't get funding to do that next step. And so really making sure going beyond not just jail to continue treatment, but the recovery-oriented system of care is important.
Yeah, the continuity of care is critical from one point to another, and that's often what we neglect to focus on when we're having these discussions. Go ahead, Gary.
Right, and I think that back in the day, when there actually used to be a little bit more robust funding in some ways for treatment, and they would do, the recovery-oriented systems of care include, it's kind of wraparound supports in a way. It would include looking at the vocational needs, the housing needs, the family relationship, family counseling, other physical health care needs, all of those things. I think, as you've been hearing from the two speakers that have more medical health care knowledge than I do as a prosecutor, that you're really dealing with the whole person, and ROSC does that.
So this is a question from our participants, which I think is perfect for right now where we are. And it involves treatment and how hopeful we are that treatment can really be beneficial. And the question is, do you believe all cases of addiction are treatable with sufficient treatment, or are some cases hopeless?
I absolutely believe all are. And I think a lot of hopelessness gets generated by the fact that people are undertreated, or maybe they're not getting medications when they need it, or maybe more typically someone who needs 3, 4, 5 months is going in and out of 28-day rehabs. There's no magic. 28 days is not a magic number. There's just often no clinical basis. So it's often treatment is so severely cut short by underfunding that it's a setup for failure. So people do cycle in and out and in and out when you could get probably about 60% success rates if you could get the right level of care, length of stay, all of the recovery-oriented system of care, all of the step down to intensive outpatient recovery housing, all of that we could do very well. I don't believe, okay, if we're dealing with cancer or heart disease, yes, some people don't make it, even when we're providing the best care. So that's going to happen. Some people don't make it, but we don't know who they are, and this is a disease, and we need to give everyone their best. We owe them as a duty as human beings, and with any other disease, to give them their very best shot from a clinical perspective at getting better.
Absolutely.
Yeah, and I would just say, even with cancers where you have very poor prognosis, the goal is to extend life and maximize quality of life. And that's kind of the framework of healthcare. I think you never want to say somebody's hopeless. And we know that because these are chronic relapsing conditions, it is expected that people will have relapses. And so you have to work with those relapses and reduce the harm. That's that whole harm reduction philosophy, which, kind of has evolved in terms of where the criminal justice or the justice side of the world is in terms of accepting some of the harm behaviors, but still working with the person and just continually redirecting them into treatment is really an important part of it.
Yeah, one of the things that we talk about in our treatment program is that women don't fail treatment. Treatment fails women. So we have a set of tools that we can use. And sometimes those women, we pull out all of our tools in our toolbox and we don't have anything left. And they haven't achieved the success that either the judicial system wants to see or they want to see. And so then it's time for them to try something else. But it doesn't mean that they are hopeless. It's just that we haven't found the right tools to be able to help them in the best way. But we have to hold the light and hope for them, because oftentimes they can't hold it for themselves.
And we do know what does not work, and that's putting women in a cage.
Yeah.
That has really, really bad outcomes.
Good point. How, if at all, does neglect and abuse increase the chances of becoming substance-involved addicted, and how do you treat these families?
So there's work by Bruce Perry that has looked at actual brain changes that you can see in brain scans from children that have experienced severe abuse and neglect. So we know that trauma in and of itself can change the brain. The beautiful thing about children is that they happen to be really malleable. And so when you give them interventions, you can see the opportunity for brain growth and development. What we also know about those brain changes with trauma is that you end up kind of living a lot in your fear-based part of your brain. And so you kind of get this disconnection between your executive functioning and your emotions and your impulse controls and things like that. And so part of what we need to be able to do with our interventions is to be able to better connect thoughts and feelings with executive functioning and training. And we do have good interventions for being able to do that.
Along that line, I think one of the things we need to look at is ensuring that all pediatricians are trained in this work, because they're missed. every educator, I think that the first goal of our school system should be to ensure that our kids are, I mean, they go there every day. This is their work, to make sure that they're healthy and that we identify these issues as early as possible so we can get them these services instead of letting them deteriorate into the juvenile justice system.
Right.
So I was just asked to point out, one of the things we did about a year ago in Michigan was we pulled all the medical school deans together for the state to talk about what was happening with the opioid crisis and to understand what they were doing for the medical school curriculum. And one of the things we discovered in that is that they were doing everything they could with the medical school curriculum, but we had a whole level of attending physicians who were training the medical students who also needed training because, again, the historical approach to training physicians on addiction treatment hasn't been as strong as it needs to be. And so that led to using some of our SOAR money to develop a curriculum to expand our numbers of board certified people that are eligible for this board certification through the American Board of Prevention Medicine. And we have, we're about to launch that initiative, and we have many of our medical schools are now partnering for that initiative to again train more people to be educators of emerging practitioners.
How do you deal with people charged with crimes not wanting drug or mental health treatment?
Well, I can just say there is a fallacy that until you decide you're ready to go into treatment, you cannot succeed. In fact, probably I would guess, based on my conversations with people who have succeeded in treatment that was commenced in the criminal justice system, is that when they went into treatment, they were really doing it to avoid incarceration or avoid jail. Hopelessness is part of this disease too. And I would say most of the people I've talked to said each of them thought they were a special case that could not get better. They had tried to quit over and over and over, and maybe treatment works for some people, but it won't work for me. I'll play the game, avoid jail, and then go on my way. As they are in treatment and as they heal and they're in a healthier environment and the brain begins to heal, usually they've been in for a while, and then the light starts to dawn that there is hope, that they actually can attain recovery, but not, I wouldn't say not necessarily in the beginning. And I know my youngest son's best friend was heroin addicted and had gotten undertreated a few times, but went into a drug court system and got better. He's got like 5 years recovery from heroin addiction now, and I don't think he thought he was going to get better going in.
I just want to add to that. There's a lot of literature on coercion and care and what that means. And one important thing to think about, and I think this is what drug courts try to emulate, is this idea of procedural justice. The more people are given information, treated respectfully and fairly, the more they feel that the treatment is what they wanted and was acceptable, even if they were coerced into that kind of care. So that, we do a lot of work. I do a lot of work with law enforcement about, de-escalation and all this. This heavy-handed thou shalt approach oftentimes is not as effective as, there is a court order, but let me explain what this court order means and what the implications are of non-adherence to that court order in terms of giving information, making them feel like the procedure was fair and just and still had to go the way it had to go. And so I think that's an important part of the coercion dialogue.
And I'll just say some of the most amazing women that I know have said when they come out of Horizons, the best thing that ever happened to me was going to jail or going to prison, or I would not be here today. So I have to say it can play a powerful role in an incentive.
So we've definitely seen that in D.C. We have one of the presiding judges of our mental health court here, and we have MAT in our correctional facility at Department of Corrections. So, I think a lot of jurisdictions are trying to push this agenda, and hopefully this will span out across the country, as you've heard from some of the congressmen.
Can I just add one other thing? Another important thing is thinking about internal motivation. And so we're seeing more and more probation officers, even judges, get motivational interview training. So even within that coercion, you're actually trying to get to that recovery-oriented system of care, because mandates really fly in the face of some of the recovery principles. And so we're always in this tension point here. But motivational interviewing or motivational strategies can really get to people to want that change for themselves.
That's a great point. I would argue even the police department could benefit. What recommendations do you have for engaging people who are addicted to drugs to participate in treatment in the community to alienate the need for criminal justice system involvement? That's a hard one.
Well, I'll just say one of the things, there are a lot of approaches, and families are desperate. They don't know what to do, and often their expressions of love actually, the way they express them actually makes things worse. It's sort of a counterintuitive approach. One is to make sure resources are available for the families because they are really hurting and they are looking for direction. I think there are any number of approaches. I think the training of professionals is going to be a way to increase that. And then we're working with the Police Treatment and Community Collaborative and treatment alternatives for safer communities. There's really just like there's a transformation in the courts with the drug court movement, there is a transformation that's beginning among police departments to actually train them in how to engage our folks. And the ones I worry about the most, I mean, obviously you want to go as far upstream as possible, but what's the most heartbreaking to me is just to see the homeless women that are just dying in mass number, either if they're not getting incarcerated, dying in terrible numbers, and they're kind of the ones that are suffering the most and have been the most failed in every way. And we cannot give up on them. And I think that the police, if we can get the funding for treatment, permanent source of funding for treatment, so we can expand the infrastructure and we can train folks like police and anybody who has contact with them in how to use motivational interviewing techniques, really, to engage them, I think that we'll do well. Better.
Are there socioeconomic, cultural, racial, et cetera, documented correlations between the type of drugs such as heroin and crack and prescription-originated addiction?
Well, that's a big question, and there's a lot packed into it. But as you heard, I think previously from some of the speakers, some of the Congress people and some of the justices, we know that this opioid epidemic first got identified as it was impacting the white population, which, in many ways was a good thing, but also a bad thing to recognize that we failed as a society to identify when there were waves of substance use epidemics going in the African American population, the Black population. And so there's lots going on right now to try and look at the demographics. We're also seeing differences in how as the opioid epidemic has been addressed, we're now seeing a rise in the population of African Americans that are potentially impacted, and differential access to care, which populations get access to methadone or buprenorphine. You could argue which is better, which is worse. That's a whole nother debate as you think about it from a medical perspective. But there's definitely racial and ethnic disparities in healthcare. There's racial and ethnic disparities in the justice system. And so where you're talking about a population that, and in the mental health system, and so where you're talking about a population that intersects with all three, you're going to see disparities in care in certain populations that are impacted and different drugs hitting different populations at different times. So, we're talking a lot in Michigan and nationally really about, looking at your data and not just looking at your data as a whole, but looking at your data in subpopulations to see, are there interventions that should be administered to target specific populations that are culturally competent and sensitive to those population needs.
And I mean, it's simply undeniable that racism is still endemic in our society, and that is reflected in, obviously it's most obvious in the criminal justice system and the disparate handling of different individuals. The National Association of Drug Court Professionals actually made it such a priority. It was one of their plenary sessions was on dealing with the issue because disparities are there. The Police Treatment and Community Collaborative that are training police departments are making it one of their priorities to first raise awareness of the disparate treatment, or who gets taken to treatment and who gets locked up. So we first got to look at that and start just saying the truth and being honest as we possibly can, and then we have to come up with strategies to eliminate those racial disparities. And it's the most obvious, and I was a prosecutor during the crack cocaine and methamphetamine epidemics, and particularly the crack cocaine, and I remember I was in there, part of that system that was so punitive and not offering help. And then when it hit this epidemic hit the white communities, and particularly wealthier white communities, then suddenly it's like, oh, we're not going to lock people up. It's a disease. So that's the correct, but that was correct back when it was crack cocaine as well, and we didn't get it.
And just to reiterate something I had said earlier, just that there's also continues to be disparities in our Child Protective Service child removals. That when you do blinded assessments of the case, you can drastically reduce children of color going into the system. So it's important.
What would incentives to the medical profession, what would be some incentives to the medical profession to step up and take steps to establish more restrictive protocols of prescribing some of these highly addictive drugs?
The states, there's a wave of legislation that's gone forward in terms of mandates, using your prescription drug monitoring, mandating lookups to the prescription drug monitoring program, mandating lower numbers of pills prescribed for acute pain disorders. I mean, there's a bunch of legislation with sticks associated with the failure to comply with that. And so I think that's important. I think as well the education and training, and again, using motivational interviewing strategies and education to really improve, and science and research to really tell us, because, there are nefarious prescribers for sure. There's also honest prescribers who were trained a certain way, who thought that they were doing the best for their patients. So there wasn't a lot of data to say how many pills does a molar extraction require after a dental procedure, so people were guessing. Now we need research, and there's more and more science is going to evolve. What we see now is nothing compared to what we'll see in 10 years. I mean, there's studies looking at genetics of pain and how really targeted responses to pain with very nuanced approaches to looking at, what your receptor responsivity is. And so the science of pain management is really going to evolve further. And I think that'll help as well to instruct the field.
And then along that line, I think insurance, requiring insurance to cover other treatment pain modalities, things,
Good point.
chiropractic, mindfulness training, cognitive behavioral therapy can be a way of dealing with it. I've dealt with herniated discs successfully with chiropractic and ice every 10 minutes an hour for many, many years, and it's been fine. And also just realizing that pain is going to be my friend, and I don't care. Because it's not that bad. So I think that it's both medical school training in terms of other ways of dealing with pain, and also making sure that insurance pays for it, because insurance really puts a lot of pressure on a general practitioner to move the patient in and out, and it's awfully easy just to give that opioid prescription, and it keeps you. A lot of this is funder driven, and so Medicaid and private health insurance need to be required to empower the physician to do other things.
Yeah, and we can't ignore pharma in all of this, because I think we know pharma has been, and there's some settlement agreements emerging around some of the pharma false advertising and whatnot. I think we have to be just as careful about pharma coming to the rescue as pharma causing the problem, because we see disparate prescribing practices in some ways related to pharma promoting certain medications with judges, promoting certain treatments with non-clinical professionals, and I think that's probably delayed access to full range of MAT across this country. And so I think we have to pay a lot of attention to pharma.
So we're going to start wrapping up. If there are no more questions from our participants, I'm going to ask perhaps our panelists, do you all have a copy of the barriers? Okay, then I'm going to, as the moderator, I'm going to just go quickly through some of